tell you a little bit about BioClinica and my personal experience with BioClinica. My mother has a diagnosis of Alzheimer's, and it is very difficult as a family member to figure out what to do. So I turned to research for my mother and went through one of the studies that Dr. Goodman recommended, and my mother got help for 4 years. I genuinely believe that that is the reason we had her with us to the extent that we did during that period of time. So I am very grateful to Dr. Goodman. I want to leave the podium now and let him have a chance to talk so that those of you who have questions can get answers and those of you who need help can get help.
Can you hear me? Yes. Well, thank you for that introduction. And that 20-year thing is just a database they get it from. So anyway, what I'd like to do is just go over our current understanding of Alzheimer's disease pathology, which is really allowing us now to lead to new and better treatments. And we'll see in a while we have very limited treatments for this disorder, and it's becoming a real problem, and it's going to be a bigger problem if we don't. Let's see. Okay, now I just wanted to start with, there's a lot of causes of memory loss and cognitive decline as we age, and the most common is normal cognitive aging. The brain ages like every other organ in the body. Our maximal brain volume is about when we're 28 or 29, and then after that, the brain starts thinning very, very, very gradually and shrinking very gradually, until at age 60, our brain starts shrinking about 1% a year, okay? From a clinical standpoint, even as early as 30, people can start getting some difficulties with what they call working memory, using memory to do something like follow a recipe. So even at age 30, these gradual declines start. But at age 45, people start noticing that they're having difficulties with word finding at times, learning new things. And it's called the tip of the tongue syndrome, and I'm sure most of us here have experienced it, and that's nothing. That's very common because it'll come to us. Neuronal plasticity decreases, making it, that just means that it takes us longer to learn something, and that's all normal. However, even though our brain shrinks, we don't really lose that many nerve cells. It's just that the nerve cells get a little bit smaller, and there's what they call dendritic retraction. Now, what we have learned is that we can delay cognitive changes that are associated with aging. And everything in our body is controlled by our genes. And we have about 25,000 genes that make proteins. However, we have about 3 billion little snippets of DNA, and so only about 2% of our DNA make proteins. The other 98% are what we used to call junk DNA, but now they call it satellite DNA, because this satellite DNA turns our genes on and off. And we've learned that what our environment is, how we behave, can turn our genes on and off. There was a study published a few years ago called the Finger Study, which is a Finnish geriatric study. They took 1,200 people and put half of them on a 2-year course of structured exercise, diet, controlling their vascular risk factors, and cognitive stimulation, and took the other half and just gave them general medical advice over 2 years. Then in 2 years, they tested their brain function, and the people who were on the courses of exercise and cognitive stimulation and good diet did 30% better on testing than the people who did not. And the area of behavior that has been most studied is exercise. And they took all these studies together that looked at how much exercise helps people with Alzheimer's disease and pre-Alzheimer's disease, and how much the medicines help people with Alzheimer's disease and pre-Alzheimer's disease. And the people with the exercise, it worked much better than the medicines we have to stabilize people's memory who had Alzheimer's and pre-Alzheimer's. And other studies also extrapolate to people who don't have Alzheimer's, who just have normal aging brain. Okay. Now, this is very important too, socializing, like everyone here. Loneliness is an independent risk factor to get Alzheimer's disease, and that's been shown very recently, factoring out associated depression and other variables. So loneliness alone is bad. Socializing is good to prevent progressive cognitive loss. And that kind of leads us into the superagers. There's a group of people over 80 whose memory is better than people who are 45. And if you look at their brains are the same volume as people at 45. In fact, there's an area of the brain in superagers that it's bigger in people at 45, okay? Now, why? We're not sure. There's some genetic component. This is cholesterol ester transporter protein. This is also our longevity gene. People who live over 100 seem to have a mutation of this gene. And we're not sure why, but it links in with the superagers. And superagers have a certain type of cell in the brains called von Economo cells. They're a large brain cell, and they're brain cells that are associated with social intelligence. Elephants have them, whales have them, humans have the most of them, but superagers have 5 times more von Economo cells than non-superagers. So again, it takes us back to the socialization issue. And then the other end of the spectrum, we have dementia, which is defined as cognitive changes that are so advanced that it affects your function, okay? The question we always get is, what's the difference between Alzheimer's disease and dementia? And the answer is 0. Dementia is not a disease, it's a description, it's a syndrome of cognitive changes associated with functional change. Alzheimer's happens to be the most common cause, but there's many, many other causes of dementia. Now, it's always nice to see a little history. Dr. Alzheimer's was a neuropathologist and psychiatrist who was the chief medical officer at the Asylum for Lunatics and Epileptics in Frankfurt, Germany. And one evening when he was on call, Frau Augusta Detter was brought there by her husband who worked on the railroad. She was 51 when she was brought to him, but when she was in her late 40s, she started getting behavior changes and memory changes, and he tried to keep her at home until she was walking around all night, every night, and he worked on the railroad and he couldn't take care of her. So he brought her in. Dr. Alzheimer admitted her, followed her for 3 years till he transferred to University of Berlin. Then when she passed away, he had her brain sent to him to look at the brain to see why somebody at that age would develop such a bad problem with cognition. Well, he looked at the brain slices under the microscope and he described the 2 signature proteins, the plaques and the tangles that characterize the disease. He presented his case report to a large psychiatric meeting. They poo-pooed it, they didn't buy it, and it wasn't until a few years later that the name of the disease was made Alzheimer's disease, published in the Handbook of Psychiatry in 1910. So anyway, it was not accepted as a viable disease when it first presented. Now, when he first found it, the average lifespan was 48 years. And he thought this was a very rare disease of middle age. But now we know, only about 4% of people lived to be over 65 at that time. But now we know it's a disease of aging. And the question that's come up is, why did Frau Augusta Detter get it when she was in her mid-40s, at least get clinically? And they actually found 200 of her slides from her autopsy in the basement of the Department of Neurosurgery in the University of Berlin back in the 1990s. So they did all the genetic testing on it to see if she had one of the early genetic forms. And some people said she did, some people didn't say she did. And so we still don't know for sure why Frau Augusta Detter got Alzheimer's disease when she was in her mid-40s. We do know it's a disease of aging, and fortunately, the population is getting older. It's estimated by 2050, the average lifespan of women is going to be about 103, average lifespan of men about 97, okay? And since this is a disease-driven disorder, if we don't find a treatment that stops it or cures it, then it's not going to be manageable by society. And you can see the incidence of Alzheimer's is rising as the age rises, and the biggest driver of this are people age 85 and over. And the people over age 85 and over are quadrupling the number of people because we're getting better at everything else to treat except Alzheimer's disease. Another benchmark is the year 2030. And in 2030, we don't know why, but African American people have twice the risk of getting Alzheimer's disease than non-Hispanic whites. Hispanics about 1.5 times. in the year 2030, there's going to be more African American people and Hispanics with Alzheimer's disease than non-Hispanic white people. And the problem is, some people say, well, maybe, social issues, and maybe, other issues, not getting good health care, diet, that sort of thing. But the disease in African American people pathologically might be a little bit different based on looking at the proteins. The problem is less than 10% of enrollees in clinical trials are minorities. So we have to do better at recruiting people who are non-Hispanic whites into these clinical trials. Now, this is a healthy brain cell. We have about 86 billion of them, and each brain cell, on average, has about 10,000 connections to it. So it's a huge, huge network. And these are very tiny. The average brain cell is about half the width of a human hair. So imagine how small it is. Now, this is normal, and this is an Alzheimer's disease brain cell. This is that abnormal protein called the plaque. It's outside the brain cell, and this is the abnormal protein inside. It's called the neurofibrillary tangle, the tau tangle. Okay. Now, these photomicrographs are Frau Augusta Detter. These are from the slide set that they found in the basement of the Department of Neurosurgery in Berlin. And this is that plaque. It's a big rounded spherical object outside the brain cells, and this is blown up, and this is the tangle. This is what Alzheimer saw when he looked at the microscope. Now, what we've found out over the last few years, that these proteins, misfolded proteins, don't build up a year or two before people start getting memory loss. This starts about 20 years before people get any symptoms at all. And this is about 10 or 15 years before it. And the most common theory of what it happens, it's the trigger bullet theory. This pulls the trigger, and this is what actually causes the damage in the brain cell. And this is the basis of what they call the amyloid cascade hypothesis. That's the most accepted theory, and it's all theory of what the mechanism of Alzheimer's disease is. And this is the amyloid that starts it, and this is gets the brain cell. Now, very recently, we have a new signature function for divine Alzheimer's disease: inflammation in the brain. Now, there's some people, as they get older, develop what they call the resilient brain. They have a lot of this and a lot of this, but they don't have any neuroinflammation. They don't get dementia. And so we're trying to figure out what the separation is. Now, because the amyloid's so important, I just want to march through how amyloid is made. It starts in this protein called the amyloid precursor protein. It's in our brain cells, and it's actually where the synapses are, the connections are. And we think that the function of it is to keep health of the synapses. Typically, it's cut in two places and taken out of the brain. For some reason, in Alzheimer's disease brains, it's cut in two different areas, or one different area. So instead of being taken out, it stays, it starts connecting to each other, starts folding, and folds up into this plaque. Okay. Now, this, and we just found this out, this is before it gets into the plaque. This is toxic to brain cells, and it collects outside the brain cells. So a lot of the targets to try to treat this disease have been looking at trying to stop this, as well as this, and this, and this. Okay. Now, we also are targeting right here to prevent this from being made. And a lot of that information is from genetics. There's a very small percentage of people who get Alzheimer's disease that runs in families. And if they have this gene, they've got a 100% chance of getting Alzheimer's disease, and it starts age 35 or 40. I saw a patient who at age 35 started getting memory loss. They thought he was depressed, and if you talk to him, his family, his uncle had it, his father had it. It tends to be multi-generational and multiple people in one generation. But anyway, the three main mutations that are associated with this early onset Alzheimer's disease has to do with processing of this protein. On the other hand, about 1 in 100 people who live in Iceland have a certain mutation that doesn't cut this protein correctly. They have 40% less of this, and they literally never get Alzheimer's disease. So it's called the Icelandic mutation, and a lot of the drugs that are being developed try to mimic that Icelandic mutation to prevent the amyloid from being cut. Okay. Now, something brand new is that, a few years ago they published a trial, they wanted to see specific mortality causes of neurosurgeons. Why do neurosurgeons die? Well, a lot of it was from airplane crashes, because a lot of neurosurgeons have their own airplanes. But it was shown that the risk of dying from Alzheimer's disease in a neurosurgeon is 7 times higher than a person who is not a neurosurgeon, okay? So they have a higher risk of getting Alzheimer's disease. Also, a person who takes care of a person with Alzheimer's disease has a 6 times higher risk of getting Alzheimer's disease himself than a caregiver of somebody who doesn't have Alzheimer's disease, okay? So those are 2 epidemiologic observations. Now, there's a very easy explanation for both of them. It's that stress. We know stress causes Alzheimer's, or is linked to Alzheimer's disease. So that was the explanation that's been around for years and years. Some people, however, raise the question, could Alzheimer's disease be related to an infectious component? Whoops. Uh-oh, there he is. Okay. So another link to this is that we used to say that our brains were sterile. You know, it was protected from the environment. Now we know all of our brains sitting in this room are loaded with microbes. You know, bacteria, fungus, virus. Most of the microbes are good from our guts. If you look at the microbes in the brain, they're very similar to what's in our GI tract, okay? However, it's also been shown that amyloid itself kills microbes. So if you take a person with Alzheimer's disease that took their brain and put it in a petri dish, it'll kill the bacteria or fungus that are in the petri dish. If you take the brain of a person who doesn't have Alzheimer's disease, it's not going to do anything to the microbes. Now, another observation is this amyloid here, it's had the same structure for over 400 million years. So if you look at prehistoric fish, they have the same molecular configuration of amyloid as we all do here in the room. So you figure if nature is going to keep something that stable for so long, then nature has a purpose for it. So a very recent theory is that possibly an infectious agent triggers amyloid formation to fight it, and triggers an inflammatory response, but the inflammatory response gets out of hand, and instead of helping, it actually contributes to the damage, the ongoing damage. Again, all theory, but that kind of fits the picture of could this be a whole neuroinflammation process started by the plaque trying to kill a microbe. Next step is that about 50% of people over 65 have pretty bad gum disease, okay? And if you look at people with Alzheimer's disease, over 70% do. And there's a certain bacteria, a very common bacteria called P. gingivalis, which causes the periodontal disease. We just completed a study, a small study, that showed everybody with Alzheimer's disease has the DNA from P. gingivalis in their brains, a huge majority. And so there's more animal data for that and more extensive human data. Actually, over 50 patients showed that. We are doing a study now using a compound that blocks the virulence factor for this bacteria. And we think that it might help Alzheimer's disease. Again, it's a study, but it's a new area of Alzheimer's that our people are going to. Now, this is a normal brain, and this is an Alzheimer's brain. Our normal brains weigh about 3 pounds, have the consistency of Jell-O, okay? But you can see that this is much different than this, that there's shrinkage of the temporal lobe, that's for memory. This is executive function like planning and attention, different. This you can't see too well, but it's, there's atrophy here. This is for navigation. A lot of people with Alzheimer's disease have difficulties in finding directions. But if you look at the motor and sensory strip, that's pretty similar. So that's why people who have Alzheimer's disease, probable Alzheimer's disease, because you can't diagnose it, we'll see in a second, unless you have tissue. But people who have probable Alzheimer's disease walk and talk and look normal, so normal for so long. Now, what's the natural history? Go anywhere from 3 years to 20 years, average about 8 to 10 years, and the lifespan is shortened by about 4.5 years in people with Alzheimer's disease. Now, if you read the literature, Alzheimer's disease is the 6th most common cause of death in the United States, 5th most common cause in people over 65. But actually, it's the 3rd most common cause behind cancer and heart disease. Because if you read a death certificate, you'll almost never see Alzheimer's disease listed as a cause of death. you'll see, sepsis and infection, aspiration, tripping and falling, but that's not the primary cause. The primary cause was actually the underlying Alzheimer's disease. So it's really the third leading cause of death. Again, it costs way over this a year, much more than the cost to treat heart disease and cancer in the United States. And much of the cost is driven by healthcare facilities. In a skilled nursing home, it's now over $80,000 a year to take care of patients. For assisted living, it's over 60,000 people. When we have a disease-modifying treatment or cure that keep people out of nursing homes, the industry of nursing homes is going to take a real hit, because now it costs over about $64 billion is what the charge is, the income into nursing homes is. And the people that are going to suffer, two are the employees. Extended care facilities now employ about 645,000 people. So that's a small price to pay. I'm sure these people get other jobs, but that's the only negative in this whole thing as far as getting people out of the nursing homes for the nursing homes. For the families and the patients, it's a godsend. So what is a natural history? People have symptoms for about 2 years till a relative drags them into the doctor to see what's going on. And it's another year for diagnosis, and then people start losing function and behavior. So it's not a linear decline. People are stable for several years, and then it plummets. This is the issue that drives people into nursing homes. Person has a risk of being in a nursing home after diagnosis, about 12% risk. If they have behavioral problems, it goes up to 60%, because people cannot be taken care of at home. And about 2 out of 3 people with Alzheimer's disease, probable Alzheimer's disease, are going to wind up in extended care facilities, and the average stay is about 3 years, and the costs are humongous. So anything we have that can drive people up this curve, keep them out of nursing homes, is going to be a godsend to the patient, the family, and society. So what about the caregiver? Even though a lot of people go into extended care facilities, more than 70% of patients are at home. 25% of caregivers, it's a full-time job. And if you look at the data, that more caregivers than non-caregivers wind up in the emergency rooms. They take more medications, they're hospitalized more, and they have a 60% higher death rate than non-caregivers. So anything that's going to help the patient is going to help the caregiver. If you look at depression, 25% incidence of major depression and Alzheimer's disease, 50% incidence in their caregivers. So what are the risk factors? I mentioned age is number 1. Genes are number 2. We've identified about 30 genes now that increase the risk of getting Alzheimer's disease, but they're not like that early onset where if you have the gene mutation, you're going to get it. These are risk factors. Like having high cholesterol is a risk factor for getting heart disease, but not everybody's going to get it. And there's a big debate on checking genes. I'm personally not a big favor of it, but a lot of people like to do 23andMe. But what happens is the ApoE is the strongest driver for Alzheimer's disease. This is a gene that codes for a protein that carries cholesterol in our blood and that amyloid in our brain. All of us in this room are either number 2, number 3, number 4. Most of us are 3-3, meaning we got a number 3 from our father, number 3 from our mother, about 64% of us. That's a neutral risk for getting Alzheimer's disease. But if you have a number 4, if you get 1, your risk is increased about 3 times. If you have 2 doses, which is only about 2% of the population, your risk increases about 10 to 12 times at an earlier onset. So, but mostly what you'll get is, if you're going to get the result, you're going to get 1E4. So, if you look at the statistics, it's neither sufficient nor necessary to get Alzheimer's disease. So, half the people with Alzheimer's disease don't have that gene. So, it's not necessary to get it. And if you have it, there's about a 30% overall risk to getting Alzheimer's disease. So, it's not sufficient. So I don't like to check it, because all it does is make you nervous for the rest of your life that you're going to get Alzheimer's disease, or else give you a false sense of security that you're not going to get it. So we don't like to check it. More females than males get Alzheimer's disease. We used to think because women live longer than men, but that's not so the case. Overall, the lifetime risk of a woman getting Alzheimer's disease is 1 in 5. Lifetime risk of a man getting Alzheimer's disease is about 1 in 10. So it's overall a little bit double risk. Now there's other risk factors: lack of education. Head trauma clearly now is a risk for getting Alzheimer's disease. And we see that in the NFL players, World War II vets who are still with us. So it's clear, and even now in the Middle East wars, we're seeing that head trauma is an independent risk for getting Alzheimer's. Vascular disease, diabetes. In fact, now they're calling Alzheimer's disease type 3 diabetes because there's such a high link between having that disorder and Alzheimer's. There is insulin resistance in the brain, and people with Alzheimer's, we'll see in a minute, have higher incidence level of sugar in their brains. So. Now, we used to diagnose Alzheimer's disease that either you had it or you had dementia. But now we know there is a long 20 years, 25 years of Alzheimer's disease building up the brain. That gives us a window to get at it before it gets symptoms. The earliest days is the preclinical, and preclinical means we can't tell. This is the time when people know there's something going on, but we don't have the sophistication yet in any of our testing, including very detailed cognitive testing, to pick it up, okay? But these people have the amyloid and the tau building up, but we can't see it yet, at least clinically, and then develop what they call mild cognitive impairment, where the memory is impaired and we can pick it up, but function is still good, so it's not dementia yet. But then goes now for another 4 or 5 years, and you start getting the dementia. It's very difficult to clinically tell between mild cognitive impairment and very early dementia. So now we're lumping and just calling it early Alzheimer's disease in most of the trials. And most of the trials we're doing are accepting patients who have pre-Alzheimer's dementia and mild Alzheimer's dementia. And we're doing some with more moderate severe, but these are the majority. This is, oops, sorry. Let me go back. Okay. This is a study we published about 17 years ago. We had a brain bank function in all of our memory disorder centers in the state. There were 15 of us. And what we did, we submitted 382 consecutive autopsy brains to compare what our clinical diagnosis was to what the person actually had. And as suspected, 3/4 had Alzheimer's disease, but only a little over half were pure. The others were mixed. Second most common was Lewy body dementia, and that's where people have Parkinsonisms and cognitive changes. Vascular dementia was 18%, but 3/4 also had Alzheimer's. Frontotemporal dementia is when people have more behavior or language problem. That's rare. It's only about 5%. But a third also had what they call hippocampal sclerosis, which is an area of the brain that it's neurodegenerative, but it's a very, very discrete area. The take-home message to this trial was, of the 89 people who didn't have Alzheimer's disease in the autopsy, 65% of them were diagnosed with Alzheimer's disease by us experts. So we are wrong a lot of the time. And like I mentioned, you can never say a person has definite Alzheimer's disease unless you have tissue to look at, either a brain biopsy or an autopsy, okay? Now, we were talking a little bit earlier. I followed a patient for 14 years who I was sure had Alzheimer's disease. Memory, he was 84, gradually worsened. After 14 years, he passed away, and the family allowed us to perform a post. He didn't have Alzheimer's disease, not a stitch of it. He had what we term hippocampal sclerosis, which can mimic Alzheimer's disease. Now, there's no treatment for it, but we did figure out how much was spent by him and his family on Aricept, which is one of the medications. They spent over $70,000 on Aricept when, one, it didn't work, and two, we didn't need it. So again, we have to get better at diagnosis. And now we can. Now, a lot of primary care doctors feel you don't need brain scans. This is a side view of an MRI. This is the brain, and this is the area that we're interested in Alzheimer's disease, this little ribbon right here on the cortical strip. This person came in who was suspected to have Alzheimer's disease, but they also had a little bit of a shuffling gait, and they had urinary incontinence. This is not normal, and I don't know how many have seen brain scans, MRIs, but this is the area of the brain that makes spinal fluid. These two areas here are blown up like balloons, and this person didn't have Alzheimer's disease, they didn't have Lewy body dementia, they had normal pressure hydrocephalus, which is curable with a brain shunt, and something we never would have been able to pick up unless we did a brain scan. So if anybody goes to a doctor and says, oh, we think you have Alzheimer's disease and you don't need a brain scan, you need a brain scan. So, and this is a perfect example. Now, this scan has revolutionized our diagnosis. This is a PET scan, which uses a radioactive tracer to label the amyloid, one of the signature proteins that are in our brains, or in the brains of people with Alzheimer's disease. Now, this area, this is black, is the tracer, and this is the white matter, and it picks it up in there. And for a couple of reasons, this is not our cortex. This is not where the action of Alzheimer's disease is. It's this 3 or 4 little millimeter strip right here. And you can see that this is black, but this is white or gray. So this person does not have excess amyloid in their brain, and this would be a normal scan, not consistent with the diagnosis of Alzheimer's disease. Now, if you look at this, keep that in mind, and look at that. You can see there is a dramatic difference. There's loss of that gray-white differentiation. Now, having said that, this does not diagnose Alzheimer's disease. All it's telling us, this person has excess amyloid in their brain. You can see it with aging. About 20% of people over 80 can have a scan that looks like this, and people with other forms of dementia, like Lewy body dementia, can have a scan that looks like this. But if a 50-year-old comes in and with memory loss and has a scan that looks like this, chances are they have Alzheimer's disease. And what we really like to see is this scan. This scan, no matter how old you are, is not compatible with the diagnosis of Alzheimer's disease. Then we start looking for other things. This is another scan. The amyloid always starts back here in what they call the precuneus, and this is mild, and this is severe, and this is just a different color of the same thing. Now, I'm going to finish up on treatment. It's been shown in the mid-70s that there's a very marked decrease in our memory chemical called acetylcholine in people with Alzheimer's disease. So the initial targets to treat Alzheimer's disease was to try to prevent the breakdown of this memory chemical called acetylcholine. And it's made right here in the basal nucleus of Maynard. And it has projections to areas of the brain. This is for navigation. This is for, over here, memory. This is for judgment and attention. This is just in association areas. So they developed drugs to prevent the breakdown of the memory chemical. The first one was Tacrin back in 1994. FDA would never approved it now because there was nothing else there. The dropout rate in the trial was over 70% from side effects. It causes hepatitis in 25% of people, but it was the only thing available, so they approved it. But the newer agents, this is Aricept, this is Exelon, and this is Razidine. These all prevent the breakdown of the memory chemical. And this is the newest one from Germany called Memantine, which works on a different chemical called glutamate. This was the last one approved in 2003 for the symptomatic treatment of Alzheimer's disease. So we have nothing for 16 years. If you look at drugs that have been FDA approved for cancer, this year alone, they've approved over 20 drugs for cancer. For Alzheimer's disease, nothing in 16, 17 years. So. And these drugs will work in some people. This graph is from the University of Pittsburgh Memory Disorder Center and looked at 1,000 people with Alzheimer's disease. And they looked at them for 3 years, and people who were on medicines like Aricept and Exelon, and people who weren't. And this is a risk graph, survival graph. The people who were on those medicines only had about a 6% risk of being admitted to a nursing home within those 3 years. That's compared to a 40% risk if they weren't taking any medicine. So in some people they work. About 60% of the time they'll stabilize people for 6 months to a year. But they're not cures, they don't disease modify, they only treat the symptoms. Then this is just talking about Namenda, where the other medicines prevent the breakdown of the memory chemical. The Namenda works over here and kind of calms the brain down, targeting a different chemical called glutamate. And like any drug, any disease state out there, you don't use one drug. Diabetes, you don't use one drug. Blood pressure, heart, and Alzheimer's disease is no different. So you use rational polypharmacy. You use 2 drugs doing 2 different things, and they work together. So we're hoping 1 + 1 = 3. And I want to mention medical foods. Are you familiar with medical foods? Okay. With a medical food, it's between a drug that the FDA approves after rigorous studies and a supplement, which the FDA doesn't even look at unless the supplement makes a disease claim. So if you look at supplements for chondroitin or for the heart, CoQ10, they always say we're for heart health or for bone health or Prevagen were for brain health in normal brain aging. If they ever made a disease claim that we can treat Alzheimer's, we can treat arthritis, FDA would shut them down. And in fact, in Prevagen, the FDA had 2 class action suits against them for some discrepancies in their claims. But anyway, a medical food is between there. Medical food looks at FDA looks at foods and regulates them, but they don't approve them for use as a drug. So they say that regulates it, but doesn't treat it. And this Axona, what this does, it's been around for about a decade. What it is, it's made from coconut oil. And what the coconut oil has are what they call medium-chain triglycerides. These medium-chain triglycerides are broken down in the liver into what they call ketone bodies. And ketone bodies, we think, are very good for the brain to use for metabolism. Now, our brains weigh about 2% of our body weight. They use about 25% of the sugar we take in for energy. And this is the brain using sugar to make energy. And you can see this is a normal, it's an FDG18 PET scan. Compare this to an Alzheimer's disease brain. The person's brain is not using sugar. They used to think that the reason is because there's atrophy, loss of brain cells, and there's just less brain cells to use sugar. But you can see a scan like this in people with Alzheimer's disease even before they get any symptoms. So we think the inability to use sugar well is a part of the disease process rather than just what they call an artifact of atrophy. So, having said that, a study was done. This is a small study, 158 people, 3 months, and they took people who didn't have that E4 gene and put them on this Axona and everything else they took and placebo. And you could see the people who took the Axona did better on testing, only 3 months. We've used this in our clinic, and anecdotally, some people do get a benefit from this medical food. Now, it's open label, and we don't know, maybe it's placebo effect, but we've seen some benefit with it. So, because of this early trial, well, let me show you. On the ApoE4, let me just go back here. I'm missing one. Anyway, because of this effect, the company that makes this did a large phase 3 trial, and it failed. But what they did is they reformulated the Axona to a different compound that tasted better, and they didn't check it to see if it caused ketone bodies, and it didn't. So this study failed, not maybe because the drug didn't work or the medical food didn't work, but because operationally it was just a stupid error that probably cost them in the millions to do. So they're talking about redoing the trial. Now, in Alzheimer's disease, we've always been happy, since it gets worse with time, if we go on medications that will stabilize it for a period of time. But we've had people come in say, I don't want to pay $140 a month for this medicine when we're no better. But these medicines, the symptomatic medicines we have that are FDA approved, treat the symptoms and stabilize people for a while. But they don't tend to get significantly better for a long period of time. So what we need is disease-modifying treatments. Additional cholinesterase inhibitors have been looked at. They don't seem to help. This is an area, the monoclonal antibodies, to get rid of the amyloid and get rid of the tau. These are actively being investigated. As I mentioned, this what they call the secretase inhibitors to prevent the amyloid from being formed. So cut it off at its legs right in the beginning. We're also looking at anti-tangle drugs. Remember, is just a stain that was accidentally found to stop the tau from misfolding. In neuroinflammation, we're targeting now, as I mentioned, the antimicrobial. Gene therapy is still a few years off in Alzheimer's, but we're right there with Parkinson's disease. And in fact, we're doing gene therapy trials now with Parkinson's disease and ALS as well. And stem cell therapy, I was a big skeptic of, because there's a lot of these stem cell clinics that have popped up all over the United States, including Florida, that are charlatans. They'll do liposuction, take your stem cells out of your abdomen, inject them, and say that they'll cure everything from wrinkles to cancer. And FDA is shutting them down. However, there is a company that is using stem cells not to make as magic to make new cells, but as an anti-inflammatory to stop neuroinflammation. And that company may have some legs. In fact, I'm on their medical advisory board, and they're formulating a trial now to take to the FDA, so it'll be done in the FDA auspices, to see if using our own stem cells are effective in treating neuroinflammation. Now, I just want to show, this is that amyloid plaque. When they give the antibody against the amyloid, only about 0.4% gets into the brain. But we think that small amount, these are the antibodies, attract the microglial, these are inflammatory cells, to also eat away at this plaque and get rid of it. Now, a lot of people say, well, if the plaque is antimicrobial is good, should we be going after it? But again, this is when the disease has already gotten hold, and it probably is that the positive effects of amyloid are overrun by the disease state progression. This is how the tau spreads in the brain. This blue, it spreads very orderly from here. Everybody, all of us in this room have a little tau right here. But if it starts spreading, then is one of the signs or one of the signatures of Alzheimer's disease. And we now know, since the tau goes from cell to cell, we can give an antibody to catch it when it's outside of the cell. And there's about 8 trials going on now looking at anti-tau antibodies to treat Alzheimer's disease. And we're very, very encouraged with this target. So I just wanted to end up on, this is something that we all can do every day. And it's estimated that 1/3 of Alzheimer's disease can be prevented by addressing the risk factors: hypertension, diabetes, midlife obesity, smoking, depression, lack of education, lack of physical activity. If we can address that, then we can decrease ever getting Alzheimer's disease. And that's very easy to do when it's healthy. You know, it's good for the heart, it's good for the head. And this can't be stressed enough. Our stress chemical is cortisol. Whenever we get stressed, cortisol goes up, drives our blood sugars up, drives our blood pressure up, and it does get into the brain. In fact, we just completed a clinical trial preventing the formation of cortisol in the brain from cortisone to cortisol. And so again, this area is being addressed. You don't need a medication. You just need to do these other things, and that alone will decrease your stress. Now, I think there's some cards around if you're interested in that, okay? And that's all I had to say. So, okay. And
We have a little bit of maybe time if you want to ask some questions. And these are the cards. They're actually on the back table, and you can get them if you're interested in getting more information from BioClinica.
yes.
I was in a 10-year study at Mayo's Clinic in Jacksonville for children of a parent that had been diagnosed with dementia. And their bottom line was many of the things that you just mentioned. Mainly turn off the TV, play bridge, play any game that will challenge your brain, do the New York crossword puzzle. And they stressed at that time, each year we had a speaker and all sorts of charts and things, that the Scandinavian countries were doing more research than anyone else in the world at that time, which has now been 15 years. Is that still true? Has America caught up or not?
Yeah, we're catching up. The one that was the finger trial, the Alzheimer's Association is now doing the pointer trial, which is the same idea, seeing if exercise, cognitive stimulation, good diet is effective in reducing normal aging, cognitive changes, as well as dementia. Problem is, we still don't know what the best diet is. You know, a lot of people say the Nordic diet, the Mediterranean style diet with low carbohydrates. We just don't know. DASH diet, low salt. Same thing with exercise. Nobody knows what the best dose of exercise is. The very recent 52 hours every 6 months, which comes to about 2 hours a week. The thing is it aerobic? Is it resistance training? It's probably a combination of both. So you have to get cleared from a medical standpoint, but the bottom line is most exercise you do, the better off for everything, as long as it's okay medically. But there was a trial just published that saw just 8,000 to 9,000 steps a day was effective in reducing cognitive decline over 5 years. Yes. Well, it's not a problem. A choline is part of the name acetylcholine. And acetylcholine is our memory chemical. So choline is one of the molecules that are used to make acetylcholine. It's probably not going to be hurt, but But again, you have to be careful unless it's looked at in really vigorous rigorous trials. For example, ginkgo biloba has been around forever. And a friend of mine, Steve Dukoski, who's up at Gainesville now, he was the great Dukoski in the movie Concussion. He was associated with chronic traumatic encephalopathy. He did a 5-year study on ginkgo. Didn't work. Now, one thing about ginkgo, if anybody takes it, it can thin your blood and cause bleeding. So people who are on very strong blood thinners should not take ginkgo biloba. That could be an issue. Same thing with curcumin. Yes.
Okay. Why don't people in Iceland get Alzheimer's? I know they must eat a lot of fish. Would that play a part, you think?
Eating fish, probably protective. Cold water fish, oily fish, probably are very good for the heart and probably good for the brain. Now, there's been issues of heavy metals. Is mercury an issue? And we just don't know. But eating fish, probably the benefits outweigh the theoretical risks of it. Yes.
I just read a study that was being done with aluminum.
Mm-hmm.
What do you know about that?
Well,
or anything?
it's been observed that the original data for aluminum was done in rabbits. They injected aluminum into rabbits, and then the rabbits started developing changes in the brain consistent with Alzheimer's disease. However, and if you look at the brains of people with Alzheimer's disease, they seem to have a higher aluminum level. But a lot of people feel that it is what they call an epiphenomena, that the brain itself is a nice substrate for aluminum to collect. So, when that first came out, people were getting rid of their aluminum frying pans, getting rid of all their aluminum. We don't have enough data yet to know whether any kind of metal like that is detrimental. Now, one of the things, too, a lot of this modeling is done in mice and rats. The thing is, mice and rats don't get neurodegenerative diseases. So we don't have good models to experiment unless short of humans. The best model for Alzheimer's disease are dogs. Dogs have amyloid exactly the same as humans, and although they don't get the tangles, they get the protein that's in the tangles very similarly. In fact, for that axona, that medical food, is that what led it to human trial was the dog data. The dog data was very, very strong. In fact, in Europe, if you look at Purina, if you look at the dog chow for senior dog chow for older dogs, they put axona in it. It's Nestle's. Or Nestle's, yeah. So, yes.
Thank you, Dr. Goodman, for an excellent talk. I'm a retired cardiologist, and I just want to emphasize a point you made, that Alzheimer's is often preventable by the same risk factor modifications that prevent heart disease. So when you're making your heart healthy and not clogging up your arteries, if you keep your LDL below 100, and if you already have some atherosclerosis below 70, don't smoke and exercise, keep your weight normal, all those good things, you're much less likely to get Alzheimer's. Specifically how each one of those factors correlates or whether they're causal, we don't know. But in general, if you have a healthy lifestyle to prevent clogging up your arteries, it'll also help your brain.
Oh, 100%. And everybody, without fail, believes that in the field. And when there's such a unanimous agreement, then there's got to be something. And it's interesting too that P. gingivalis, the bacteria from our gums. We brush our teeth, we can get a bacteremia. We get the bacteria in our blood. It collects on plaques, and it's been shown that we think that fighting the P. gingivalis is good for heart disease, and it's probably related to inflammation. Again, going to the dentist twice a year, 3 times a year to get a good cleaning is very important, we think, for general health. Yeah.
Dr. Goodman.
Yes.
I understand that in Scandinavia that they are building villages to care for Alzheimer patients, where the village is structured to meet an Alzheimer patient need. And so my question is, do you know of any movement in our country to do something for the people who have Alzheimer's?
There's a push for that, and now you'll see that a lot of extended care facilities have Alzheimer's dementia units, locked units for the patients very severely impaired. That's not what people need. What people need are environments that are dedicated to the patient, where they go back, their environment is very familiar to them when they were still had normal cognitive function. Music, pictures. So that's a push now in the more progressive, the more enlightened places, that they're trying to design extended care facilities that match the person's normal environment. Music therapy, for example. Music triggers emotion, which is in what they call the amygdala of our brain. The emotion opens up memories. And music therapy is extremely effective. Having pictures of family members around. Again, so we're getting there, but we're not there yet. So, yes.
I take Enbrel for rheumatoid arthritis, and it's been out for
Sure.
years. It's one of the first biologics, and I saw something in I can't remember where it was, but that Pfizer has said that Enbrel has opportunities to help Alzheimer's patients.
Yeah.
Do you agree with that?
Yeah, they buried that. What happens is Pfizer puts out Enbrel, and they've, based on pharmacy data, they noticed that the people who are on Enbrel had less of a risk of getting Alzheimer's disease. So they were encouraged to try to extend that a little bit to look to see if Enbrel would be effective. Well, Pfizer has gotten out of the Alzheimer's disease business. In fact, they got out of the neurology business. They are not doing any more neurology trials because they were too costly. So there's other drugs like Humira, and they're anti-tumor necrosis factor drugs. And again, it fights inflammation and getting back to this neuroinflammation issue. So it might be valid. Now, if you look at the data, people who have rheumatoid arthritis have a less of a risk of getting Alzheimer's disease. So for years, they said, well, maybe rheumatoid arthritis protects you. But then it was thought it was the non-steroidal anti-inflammatories that they were on that protected them from Alzheimer's, not the disease itself. So then they did a bunch of studies looking to treat people with Alzheimer's disease with non-steroidal anti-inflammatory agents. They all failed. But again, we're treating people when they're at the end stage of Alzheimer's disease, when they're in the dementia. If you go on non-steroidals 20 years before, would that protect them? And we don't know, because being on non-steroidals for a long time can have complications. So it's not recommended to take, but could it prevent? And we don't know. But I think the Enbrel data, the inflammation is strong. I'm disappointed that Pfizer wouldn't at least push it a little bit.
This, I think, is going to have to be our last question.
Okay.
Yes, and Dr. Goodman, does bipolar fit into this picture or the equations at all?
Well, if you look at a person who has not had depression, for example, and develops later life depression, that frequently is a marker of an organic Alzheimer's disease process going on. Long-standing depression may not, I'm not sure, is a risk factor, and bipolar, I'm not sure, is a direct risk factor to get Alzheimer's disease. So, but if they looked at, there's a study published years ago that looked at autopsies of people who successfully committed suicide. There was a high instance of Alzheimer's disease pathology in those brains. So there's a link, but it's not clear at all.
Dr. Goodman, thank you so
Thank you.
much for joining us today.